So in this lecture, I'll be discussing stroke treatment in an acute setting. Treatment of treatments you can take so that you can prevent future strokes will be discussed in a separate lecture, and also the corresponding drugs for that. So in an acute setting, first thing you want to do when a patient presents with stroke is stabilize vitals. Stabilize vitals. So what does that mean? First, consider blood pressure. Blood pressure. So there's three considerations things you have to take into account. One, usually patients are going to present with hypertension, but don't use antihypertensives unless blood pressure is greater than 220 over 120. So then you can use antihypertensives are okay. Hypertensives, okay. Second is the exception to this rule is if you're going to administer thrombolytic therapy. So thrombolytic therapy refers to treatment option where you break up a clot, and we'll discuss this in a few minutes. Again, if you want to do thrombolytic therapy, stabilize blood pressure below 185 over 110. Keep it there for 24 hours. So antihypertensives, okay. But which antihypertensives do you use? So there's two first-line treatments, and most people usually have to revert to the second-line treatments as well. These are acute, reversible, and titratable IV agents. So labetalol is the first one. Second one is nicardipine. And our second-line treatment that most people end up using anyway is called nitroprusside. So these are the three antihypertensives you want to use in the acute setting. There's many other antihypertensives out there that can either cause prolonged decrease in blood pressure or like a very sharp decline in blood pressure, but those are often also associated with an increase in stroke. So you don't want to give a patient antihypertensives that can cause stroke if they're suffering from a stroke. So next thing you want to check is respiratory rate. So respiratory rate, maybe they're hypoventilating if this is the case, and if they're vomiting. So vomiting, hypoventilation, then intubation may be necessary. You want the brain to get all the oxygen it can. You want the brain to get as little CO2 as possible, because both can lead to severe consequences and just exacerbate the brain damage. So brain intubation is an option that you should consider immediately. Another vital sign, temperature, is something you may want to get under control. If there's a fever, for example, strokes could be due to some infections. So you want to find the source. If it is an infection, find the source and then treat this. Or you can just give acetaminophen. So that's it for stabilizing vitals. The next section of this talk is going to focus on how to reverse stroke conditions quickly. So reverse stroke conditions. How to prevent permanent brain damage from occurring too quickly. So the first thing you want to do is this like therapeutic regimen we've always been throwing around, thrombolytic therapy. So it's called alteplase, thrombolytic therapy, fibrinolytic therapy, reperfusion therapy. These are all different words that you can use to describe this recombinant tissue type plasminogen activator, so RTPA. And what it does is it takes, so it degrades fibrin, which is a component of thrombi, of platelet plugs. So as we mentioned in the pathogenesis lecture, so it degrades fibrin, and the way it does this is that it converts. So what RTPA does is it takes plasmin, converts it to plasminogen, And what plasminogen does is it degrades fibrin, which is a component of clots. So then the clots might degrade. Fibrin. So you don't want to use this for a hemorrhagic patient because the RTPA can actually cause hemorrhage. So there's various inclusion criteria and exclusion criteria you can use to quickly identify patients that should take RTPA. So first we're going to go over the inclusion criteria. So the inclusion criteria are if you know it's an ischemic stroke or think it's an ischemic stroke, or there's no time to take CT and you're sure it's ischemic stroke based on history or physical, go ahead, give them RTPA. Symptoms have to, like onset, the onset of the stroke has to be less than 4.5 hours ago. That's the cutoff. There's not many exceptions. And then the patient has to be over 18. Exclusion criteria are a little longer. So the first thing you want to look at is history. So whether the patient had if they had a significant stroke or head trauma in the past 3 months, don't give RTPA to them. If they've had a hemorrhage, intracranial hemorrhage in the past, don't give RTPA. If they recently had surgery in the brain or in the spine, don't give RTPA. Additional exclusion criteria are clinical symptoms. So, for example, if you cannot stay, so clinical. So, one thing you can consider is blood pressure. If you can't get blood pressure over under 185 over 110 and stabilize it there, don't give them RTPA. If glucose is less than 50, so if they're suffering hypoglycemia, if their glucose is less than 50 mg per DL, don't administer this treatment. Other exclusion criteria you want to consider as the labs start rolling in are hematologic findings. So if their platelet count's low platelets, don't give it to them. If the INR, which is a measure of how fast blood can clot, if the INR is too high, so it takes too long, don't give it to them. Don't give RTPA to them. Another consider. So next session, another exclusion criteria, just based on the CT scan. So if you looks like a hemorrhage, don't give them RTPA. That's what the CT is for. And so these are the main exclusion criteria. There are some other ones. And one thing you want to consider for RTPA is presenting it with IV if it's too late, or if there's not enough time for CT. Go ahead and give them the IV RTPA. So that's the first thing you can do to reverse conditions is the RTPA therapy. A second thing to reverse conditions is just maintain serum glucose levels. Serum glucose levels could be too high or too low. So 60 to 180 mg per deciliter. So you want to rapidly correct this if it's too low, but studies have shown that adding IV insulin doesn't help if glucose is too high. So just correct if low. I mean, hopefully it stays, hopefully they're not hyperglycemic, but IV insulin hasn't been proven to be effective in increasing or decreasing mortality rates. Another thing you can do to reverse treatment, reverse conditions quickly, is just to make sure, another thing you should check for is swallowing. So make sure they can swallow food before you feed them or before you give them drugs. And another thing you want to check for is just make sure they're in the supine position. And then you have to make a decision whether you want to lean the head at 30 degrees or 0 to 15 degrees. So if it's acute phase stroke and at high risk for for example, intracranial pressure or aspiration or worsening cardiopulmonary status, then you want to give put the head at 30 degrees. So otherwise, keep them laying flat on their back, 0 to 15 degrees. And another thing you want to do to like reverse, hopefully prevent permanent brain damage, is you just want to get them moving. So within 24 hours to 48 hours, you want to get mobilization. And so then there's other immediate treatment options that we'll cover in the next lecture, as well as treatment options to prevent further strokes if you've already had one. Thank you.